I will utilize a Kelly clamp to mark the skin surface between the base of the uncinate process and spinous process, utilizing a small skin marker. A small skin wheel will then be raised with 1% lidocaine using either a 27 or 25 gauge needle to anesthetize the skin. I will then use a two-finger approach, utilizing my third finger and second finger. My third finger or middle finger will displace the trachea and esophagus contralaterally, while my second finger or index finger displaces the carotid artery ipsilaterally to set up a safe window between the spinous process and base of the uncinate process. Here is my safe area of access where I will place my needle. My third finger and second finger remain in close apposition to the bony anterior vertebral body line, and these fingers will not leave that line until I gain access into the mid-intervertebral disc. After advancing towards the anterior vertebral body line, I switch the fluoroscope to a lateral projection, and only in lateral view will I enter the anterior disc. I will then swing to AP before I get a deep bite of disc to ensure that the needle itself has not strayed laterally to one side or the other. And then in lateral projection I will subsequently advance the needle into the mid portion of the intervertebral disc carefully, while either twisting or slowly pressing the needle into the disc. Advancements should be done gradually and without great force. A follow-up AP radiograph will demonstrate that the needle is within the central portion of the intervertebral disc. After placing the needle within the disc, it is important to withdraw the stylet while advancing the introducer needle itself, such that in a thin-necked person the introducer needle does not pop out after removing the stylet itself. While placing the wand through the introducer needle, it is important to also mildly withdraw the introducer needle while advancing the wand to ensure that the wand does not extend beyond the posterior vertebral body line and come to rest upon the spinal cord or other neural structures. The dotted red line denotes the point of no return along the posterior vertebral body margin, which denotes the anterior aspect of the thecal sac and spinal cord. Following placement of the wand into the central portion of the disc, 3 passes may be performed at 5 to 10 seconds apiece, whereby the wand itself will be rotated utilizing real-time fluoroscopy after the coag button has been pressed for half a second to ensure that there is no contact with neural structures. All of these placements should always be performed from posterior to anterior, such that the wand is never advanced itself into the intervertebral disc. In this way, we will not damage the wand tip. The ablation is performed utilizing slow rotational movements without moving the wand from anterior to posterior. Again, rotations are performed utilizing a power of 2 on ablation mode. 2 to 3 ablations may be performed for each disc level. After the wand has been positioned 2 or 3 times, it will then be necessary to also advance the introducer needle over the wand while removing the wand, such that the introducer needle resides within the central portion of the disc. Gauze is utilized while quickly removing the needle in one movement. Mild pressure is then placed along the area of access for 2 to 3 minutes. Carotid artery should still be able to be palpated superior to the area of access. Here we see MRI images obtained in both axial and sagittal plane of focal herniations at the C5-6 and C6-7 levels. Anteriorly, you can see the carotid artery and trachea, as well as the internal jugular veins. Again, the access angle is between the carotid and the trachea on the right side. Here in sagittal view, you can see the focal herniations at both the C5-6 and C6-7 levels.